Empiric to me has always been a bad word. It means you don't know why you're doing it. Don't have any evidence, don't have any proof. You're sort of just guessing. I mean, when you think about everything, I guess it's all a guess. We don't know anything absolutely. But certain things we are more certain of. Many things we are certain of. Some things we are not certain of. And I guess the traditional way I view it is we're certain of most things. And we do things because we have a reason, we have a rationale, we have an explanation. We could justify it if somebody were to ask. Empiric, not really justified. You bring up reasons like old wives' tales, somebody else told you to. They're not really good reasons, but they are reasons, but not great. Not logic based. Not based on any concrete data. I mean, I would say evidence, but I hate the word evidence either as well. So recently I had a few cases that made me really rethink how I did stuff because does the ends justify the means? In the medical field, are you just supposed to do what's right and leave the rest up to God? Quote from Dean Winslow. I don't know. I don't know what the right answer is. But I'll tell you the two cases and you can decide what you think about it. So the first case is older man. Doesn't actually look that old, looks pretty good. No real medical issues. Doesn't see the doctor regularly anyways. Comes in, coughing, short of breath, diagnosed with pneumonia. I'm pretty certain he has a pneumonia. Why? Because we have a CT scan looking for clots in his lungs, and there are none. But it shows consolidation, some stuff there in part of the lung. That's as good a diagnosis of pneumonia as anything, basically. His white count's not elevated, having some fevers. All that is going to fine for pneumonia. Because many older people's white counts aren't elevated. The first day when I go in to see him, I say, oh, it's funny how we use two different antibiotics, but we cover you for things in the community, things that aren't really serious though for most people. It's not for people who aren't older or very young. Things like mycoplasma. It's classic for walking pneumonia, which means you're not that sick. You're walking around still. He wasn't on oxygen. He didn't look horrible. He's getting treated. He should get better. Maybe he even wants to go home today. We'll give him some IV antibiotics at home. No, no, his wife said no. Okay, we'll keep him. The next day, a result came back. Somebody had ordered a viral pathogen panel. So we don't call a respiratory virus pathogen panel because it actually tests for many other things. We just call it respiratory pathogen panel for a generic term. So it tests for bacteria as well as viruses. And it's just a PCR. It could test for things and diagnose things like mycoplasma, which is actually very hard to grow because it's fastidious. Fastidious just means hard to grow. So he has it. But I thought he wasn't supposed to have it. He's not supposed to be that sick. That's strange, right? I ran it by a lung doctor. He said it's okay. I checked the procalcitonin, which takes a while to come back in my facility, especially on weekends, maybe a whole day. Normally it takes half a day. It's sky high, 40. One is good enough to say you have a good pneumonia. 40 is crazy. And it kept coming down. He said he felt better, but I don't know that he felt that bad to begin with. I mean, he's not one of those people who would, exaggerate how he feels. But the thing is, it just was very strange to me how things kept happening the next few days. A few days later, he was on oxygen. We discovered he had heart failure. He had a fast rate and he had atrial fibrillation. But his ultrasound of his heart showed a normal size left atrium, which means he couldn't have had it for a long time. Doesn't have it chronically, otherwise that'd be enlarged. The left atrium is the one that fibrillates. Why is he doing worse when he's supposed to be getting better by his numbers? His calcitonin, which is a measure of the infection in his lungs, keeps on going down. Before I even called the lung doctor, I looked it up. Some cases mention fulminant mycoplasma. Like many things, we explain it by the body's reaction is what really hurts you and kills you. And treatment for that is not just antibiotics, but steroids to calm the body down. But I've never seen it before. I only read about it now. What am I supposed to do? My default instinctual response is find somebody smarter who knows this. That's why I asked the lung doctor. But the problem is, we work together, people. We know them by name. Here at my current place, when I meet somebody from new for the first time, hey, I haven't seen you before. We chat a little bit just so they could get to know you. We have cordial relationships. We protect each other. We help each other. And that's why I feel hard pressed to say things, ask questions when you know pretty much the answer is no, and it's embarrassing. If I asked the lung doctor whether he'd seen a mycoplasma pneumonia that's fulminant, he would say, I don't know what you're talking about, if you were blunt and honest. And now he would hedge and try to talk his way out of that question. Basically, he hasn't seen one before. I dare say most doctors in the hospital haven't seen one before. There's only a few case reports out there, and most of them are in children. Very sparse in adults. But as you know, children and adults sort of are the same. Old adults, young children, all at high risk for these diseases that don't really bother the rest of us, like pertussis. It's just annoying. Had it before, it's a cough. Feel like throwing up, cough so bad you feel like you're going to pass out. You get over it. Takes weeks though. Nothing much you could do about it after it starts. It doesn't kill you unless you're old or young. So here's the deal. I kept asking the lung doctor every day. Talked on the phone every day. Patient sort of kept on getting worse. Finally, he got really bad. Lots of oxygen requirements. Lung doctor told me to consult everybody under the sun. When you're both sinking, you want everybody involved. I felt bad when I saw the patient because he was worsening. Told him I was involving other people. But the truth is, I knew the treatment. Steroids, there's not really that dosage everybody thinks about. For the vast majority of cases, we use way too much. So what do you do in this case? Well, this company lung doctor gave him a whole bunch of steroids. He got better. I knew he would. I knew it wasn't heart failure like the lung doctor said when he talked to me on the phone the day prior. Why? It's simple. His heart's been like this. We got fluid out of him. It's not improving. X-rays don't show you much. They look the same. They have some changes. You think changes could be fluid? They could be. Think if they're really quick, they're fluid. It could be. Ours presents the same. Fulminant mycoplasma probably presents the same. What do we do about it? We give steroids. What was I waiting for? Another doctor do it. Why? Do I not have the ability to order steroids? I know, I totally do. Many people do. But I don't. And here's the thing. Empiric. I've seen many doctors use steroids, especially lung doctors here in the hospital I work at. I don't know if that's justified. For the first time in my career, which spans probably 15 years, I've seen steroids given for pleurisy. Pleurisy is a term you don't hear very much. Lung pain from infection. Pleuritic pain is more common. Happens a lot of stuff. But it's pain upon deep inspiration. When you take a deep breath, it hurts. But pleurisy, yeah. It's like saying somebody had an attack. Oh, you mean a stroke? Yeah, attack. Dropsy? Yeah, a stroke. We don't use those terms anymore. What is my objection? Why am I anti-steroids? These steroids have proven they're harmful in many cases. Not the short term that matters, the long term. Short term, they make people feel better. I was talking to one of my colleagues about this, and she was mentioning, yeah, she trained at a academic center. They're very sparse about using steroids. Don't just use it willy nilly. They're dangerous. But yeah, they make people feel better. She's in more community hospitals, right? Because you're trying to make people feel better. But the question is, if you make people feel better right now, it's bad for them a few months down the road, a year down the road. Is that justified when you could have gotten by without it? I find that hard to accept. Sometimes I find this whole empiric thing, just doing things willy nilly, hard to stomach. But then I don't want patients getting worse. When people are crumping, it's justifiable to throw everything at them. Well, before they're crumping, before they're getting worse. If it's steroids, though, it's a risk. I don't know. Is it worth it? I can't say. It's hard for me to treat something I've only read about. It's easy to treat something I've seen before. And that brings me to my next case, which I'll tell you about.